Good morning, it's Dr. Rutledge, and this is my short version of a longer presentation. I just looked at the long version, which has too many slides to even mention, and it takes over a half an hour. So this one is going to be short. It's supposed to be under 15 minutes, and we'll do our best, so we'll get started. So I appreciate the invitation, and I thank the invitees, especially the many brave surgeons who fought with me over the past 25 years to bring the MGB to international recognition, and now in the United States as well. I'm also happy to announce my association with Dr. Ilan in Tijuana and San Diego. And I have to give thanks to Dr. Kular and Dr. Magenda, who put up with me for 2 years during the pandemic in India. So thanks to my colleagues over more than 10 years and thousands of MGB patients that we have cared for together. Here's an old picture. My patients from the United States about 10 years ago, and the map has extended since then. And this is my travels, excluding Australia. Couldn't get it in the picture, but I've been there also. And so we're going to talk about perforated marginal ulcers today, and I have an hypothesis to tell you about today. Hope I can convince you and hope you can find it useful. And that is, it's not just acid. And often the surgeon is the problem, and I call that the YOMEGA effect. And I'm going to talk about mistakes, misunderstanding the etiology of perforated marginal ulcers, and say that that can drive our decision-making for prevention as well as treatment. And I'm going to talk about twisted, devascularized pouch, anterior Gastro-Jejunostomy causing a twist, ischemia, surgical technique as potentially unrecognized culprits, and that has implications for prevention, as I say, as well as treatment. So here's a brief summary before we even get started. You can just watch this and kind of know everything that I know as far as this topic. And so first of all, it's not only acid. That's one of my primary educational teaching points, and basically an ounce of prevention is worth a pound of cure, 1700s by Benjamin Franklin. So, and if the acid were the primary etiologic agent in marginal ulcers, then we should see some things. So first of all, remember something that's obvious, which is stomach acid is proportional to the parietal cell mass. That's basic general surgery. And most studies show marginal ulcers are much higher to extremely much higher in the Roux-en-Y versus the MGB, and we'll show you some data to support that. But the MGB has a large pouch, which means it has a greater parietal cell mass, so it has greater acid production. And if acid production and pouch size made a difference, then the MGB should have a much greater incidence of marginal ulcers, and that's not the case. And we'll show you some data to support that. And recall, there were a lot of people, still are some people who say, oh, you have a marginal ulcer because you left the pouch too big. You may remember the micro pouch, and we'll go ahead and talk a little bit about that. I think serious misunderstanding. And so I say it's not only acid, it's obvious. And my hypothesis, it's ischemia and other surgical technique and postoperative management features. And so that's my take-home message I'd like to pass on to you today. Here's one of the topics you might have some skepticism about. This is a study from the New York State database. And basically they showed over 1 out of 10 every Roux-en-Y patients gets an ulcer. I mean, if MGB was like that, you'd think we were doing it like the YOMEGA people do it. So it is extremely high risk. And here we'll see that in a survey recently of some high volume MGB surgeon experts, that half of them said that the rate was not 10%, but less than 1%. So more than 10 times, maybe even as low as 100 times less. And it turns out that those people who thought it might be a higher rate were people with less volume of MGB experience. So just in that survey alone, we might be seeing that surgical technique might have an association. So the large pouch theory, remember this. This is from 2017, so it's not that long ago. People were still saying this. They thought, oh, there's a big pouch, so there's a lot of acid. That's why you got a perforated marginal ulcer. You should just redo the Roux-en-Y and decrease the pouch size. Well, I don't agree with any of that, and I don't think it makes much sense because we have the MGB for comparison, large pouch and low incidence of marginal ulcer. So I don't agree. So a simple summary, what to do. So we'll do that real quickly because I want to finish in time. So I say think prevention first. And so I'm supposed to talk about the surgical approach, and I will, but prevention, 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 rather than you being up at night repairing this, what if you could modify your surgical technique or your post-op management and decrease the rate of marginal ulcers? And so we'll talk briefly about that, even though that's not my assignment. Prevention first. So as far as treatment for perforated marginal ulcer, I think it's very straightforward. I'm sure that we get some complicated questions, but in general, the vast majority, 90% of perforated marginal ulcers is at the Gastro-Jejunostomy. Suture and Graham patch is all that's necessary. Drains if there's purulence and it's appropriate, and a feeding tube, again, if appropriate, given the clinical situation. The other version of this same disease, which can be much more deadly and complicated, and that's massive disruption from the perforated marginal ulcer. Fortunately, it's rare, but the easy treatment for a primary MGB, that's an MGB that's not done as a recovery operation for a failed sleeve, you, in a very difficult case, you simply divide the Gastro-Jejunostomy, repair the bowel if necessary, and then do gastrotomy in the gastric pouch and a gastrotomy in the gastric remnant, do a gastro-gastrostomy and close it with suture and get out. In my opinion, almost never do a Roux-en-Y. There's the now so-called Billy exception, which we'll talk about. T-tube drainage, I think, in consultation where I've talked to people around the world who've done that, it's frequently lead to death. And so I don't recommend it. It's leads to sepsis and uncontrolled sepsis and death. And vagotomy doesn't make any sense to me because we know it's not primarily an acid-related disease. Acid needs to be there, but it's not the cause. So again, the event where you could do a Roux-en-Y in my case is if you had a MGB done for a failed sleeve and you don't have a significant distal gastric remnant, then I might consider Roux-en-Y reconstruction, but I have never had to do that. I have consulted on one MGB rescue for a failed sleeve. And in that case, there was a perforated marginal ulcer, and we were able to anastomose the proximal to distal gastric pouch with no real difficulty. We have asked the same question of a group of surgeons who have had experience with over 10,000 MGBs, and they said that they did a conversion to Roux-en-Y rarely. About a third of the group did it sometimes. A small part of the group said never, and I would add my name to that in addition, so it'd be a little bit higher than that number. There was one person who said he did it always, and he was a relatively new MGB surgeon, so he probably needs some more experience. Okay, summarize again, and all we're saying is really simple. Negative exploration, get out. Positive exploration, type 1 or type 2. For type 1, free lateral perforation at the GJ, intact. For the rest, gastro-jejunostomy, the pouch and the small bowel, suture repair of the GJ perforation, aspirate 2 JP drains, and maybe a feeding tube if the patient appears unstable or needs further nutritional support in your assessment. For type 2, this is rare, fortunately. It's where you have massive damage to the gastro-jejunostomy or complete disruption. The patient is septic. In such a patient, you need to get in and get out. In other words, you don't need to do something bad, but you need to be expeditious and not fool around. You're not going to be doing a tummy tuck, breast augmentation, or a rhinoplasty. You've got to get in and get out, or so you don't kill the patient. So briefly, in summary, short, simple 3 steps. Divide the gastro-J, close or repair the small bowel as needed, and then do a gastro-gastrostomy, the pouch to remnant stomach. Drain, get out, plus or minus a feeding tube. Again, T-tube, vagotomy, and conversion to Roux-en-Y, I would say almost never, except for the Billy exception. Again, same thing. And my own hypothesis is that the Roux-en-Y is almost never necessary. Okay. Again, Roux-en-Y, no. Small bowel only patch, no. T-tube drainage, no. Other truncal vagotomy. In my consultation experience with surgeons around the world, these led frequently to very severe complications and deadly outcomes. Again, we'll just go back through the history. We've known about this for a long time, and this is an older study that said basically one of the most problematic postoperative complications is marginal ulcer. So it's a well-known problem. Here is, again, a reminder that this is one of the best studies because it looks at the entire state of New York database, and we see 11% at 8 years. 1 out of 10 Roux-en-Ys gets a marginal ulcer. Why? It's not because they have a big pouch. Okay, let's look at one of these. Here's free air, purulence in the abdomen, adhesions, dissection. There's a defect, repair the defect, omental patch, and we're out. I don't think a vagotomy is appropriate. I think Roux-en-Y is rarely necessary. And so we just summarize again. Type 1, simple. Type 2, less than 10%. Debris, dead, non-viable tissue. Ideally, divide the gastro-jejunostomy, gastrostomy, and drainage and get out. Now, why are we in this soup in the first place? Let's do a little bit of talk about prevention, even though that's not my primary goal, but we'll just do it quickly. If you look here, we see the lesser curvature there with the red arrows. That's the vascular supply. The black dashed, double dashed line, that was the greater curvature. This is the neo-greater curvature. It has no blood supply. Everything has to come from the medial aspect. Now, that's fine until you put a staple gun in. So if you put the staple gun in medially, then there's a possibility of collateral blood supply going around that staple line and up into the distal tip. On the other hand, if you move that staple line laterally, like in the red dashed line, then that potentially has a dead ischemic zone along with a batch of titanium foreign body. I think this is commonly a cause when I consult for the marginal ulcers later in life. Again, same recommendations. Again, Billy exception. What we think is doing the MGB wrong with a twisted gastric pouch, a neo-gastric pouch should not be twisted. Again, if you obstruct the outflow, that means persistent exposure of that potentially ischemic area to acid, bile, and enzymes. So, and you don't want to twist the pouch. And again, there's an invisible illness because it can look okay on upper GI. But bottom line, those are the things I suggest, and I appreciate your opportunity to talk with you about this. So I'm hoping for questions, and we have a longer version of much more detailed presentation on the internet, and I'll put a link to that below.